Hello. Coming in there. Okay, 3:30. I posted earlier about 2 hours ago we were going to come on live. I wanted to answer any of the questions people had about. It doesn't matter. I mean, injuries, pain. We didn't get any posts necessarily, but if anybody's on live, please post it in there. Jake and I will answer the questions. Let's go back. I better introduce ourselves.
Yeah.
I'm Chris, physical therapist. We are the herniated disc experts here. We combine physical therapy, chiropractic, treatment, and care. We specialize in this kind of thing. We call musculoskeletal pain, mechanical pain.
Yep.
Any way you want to call it. It can be it can be as simple as muscle, joint, spine pain.
Yep.
And this is Jake.
Yep. Jake with Essential Motion Spine and Sport. So yeah, we're here to answer any questions you guys have. So holler at us, throw it in there, and we'll talk about it.
We'll just kind of briefly talk about some questions that I've had written down from other people in the past, and then if someone comes on, I see a couple people watching now, but if you have a question about any kind of pain or even a rehabilitation technique, a chiropractic technique, a concern like, oh, what should I do with this problem, just drop it in the comments. We'll answer it. But first off, I wanted to ask Jake here. So I kind of write these things down when I see them in some groups.
Yep.
And there was one person that had a question about, buttock pain. If it's normal to feel like you have just, hey Dave, thanks for watching, my man, I appreciate it. If you have just like one-sided, like just here, like kind of that posterior, buttock or glute pain.
Yep.
If that's kind of feels like it's bruised. Is that normal for it to be just on one side, or should it be, should you have back pain if you have butt pain, or can you just have that glute pain with this kind of injury?
So if we're specifically talking about a herniated disc here, is that what we're going?
Yeah, and it could be anything, that if people have a glute pain, what would we look into or try to determine, if there was a glute pain?
So just reasoning through it. Okay. Mm-hmm. So with glute pain, we know. We talked about this last week, that roughly 3/4 of all hip complaints, that would include the glute area, stem from the low back.
Yep.
So obviously we'd have to start our exam there. We'd have to match, obviously with the history findings that we find. Then we'll do a physical exam, but we'd screen the low back regardless.
Yeah. Our mental scales are already like, 75, 80% low back, 25, 20% hip, we're thinking already.
Right.
So we already kind of have that. There's Sarah. She knows this stuff already. We're already kind of
thinking
coming into that with a little bit of a tipped scale.
Right. Until proven otherwise.
Yes. So we're gonna move it and prove it until it tells us nope, it's not that.
Yep.
But
so we'll do some movement screens. We'll tease out the low back. If it turns out to not change much with different repeated movements, then we'll kind of go more towards looking into the glute and hip area, and then we can have things bursitis. Glute tendon issues. We can have hamstring tendon issues.
Yep. We're going to start with on top of our mental funnel.
Yeah. Of
all the possible things that it could be. It could be a low back or disc issue. It could be just a a mechanical pain issue that just doesn't have no reason or specific tissue. It could just be mechanical low back pain and or glute pain. Like ischial tuberosity, glute medius, anything that could possibly be. And then based on going through, our questions, which is why it's important that, you kind of have felt this and what changes it, what's better, what's worse.
Yep.
So going through subjective and then go like the objective movements you were talking about.
Yeah, definitely.
We'll try to funnel down and start hacking off things. Well, can't be that, until we can drop it into a bucket and figure out what you got.
Exactly. Yeah.
What are some things that would cause like just glute pain?
Yeah, so just glute pain, starting from low back, you could have, it doesn't necessarily have to be a disc issue.
Thank you, Jared. Thank you, Jeffrey.
But just
drop us a question here.
Low back issue in general, typically low back pain is discogenic, coming from a disc. So that, you don't necessarily have to have a herniated disc for that low back pain to refer down to the glute region. So that's probably one of the more common ones to have glute pain. Question here?
Oh, we do. Yes, we'll get right to that one. Okay, Alana has a question, which is perfect. Thank you, Alana.
Okay, that's good.
I appreciate that. We were trying to work on her low back as well. She's had some questions in the past. So, so we'll finish up on the glute pain. It could be something from the back, absolutely.
Yep.
It could be something, actually I mean, if the person had, a specific mechanism, like if they were
That
jumping
helps.
or
Yeah. Okay,
had a fall, that could totally change things,
that
right?
changes everything, yeah.
Okay, so Alana says, can SI joint pain be mistaken for herniated disc pain? And can you see the I think she means SI because it says SI joint pain in an MRI? Oh, that's such a good question.
That's a good question.
Oh man, Alana, this is like perfect. This is why we had this. Is perfect. How do you want to do? Let's do the first one.
Okay.
So can the SI joint pain and a herniated disc pain mask each other, or I think you said be mistaken for?
So
What do you think?
yeah, so the SI joint pain. I wish you got a piece of paper and a pencil so I can draw something out here.
Yep.
Get a pen handy.
Yep.
Okay.
So absolutely it can be because they're so close together. You got to see the visual of how close. So when you're talking about the pain's going to drop at the pelvis, right? Your SI joint and then the sacrum and where the discs sit right on top of there. We're talking just a few, inches away. So that's very tricky to see that, and they can absolutely mask each other or be mistaken for one another. The difference is in the presentation of how they respond to movements, positions, loads, and the person's subjective, like how they feel with certain things.
Okay.
That's the difference. But here, I'll kind of pick this up so you can see, because then Tyler's got a question here as well. So
Cool.
here, I'm going to flip this around
this over,
because it's going to be. They don't want to see me anyway.
Yeah.
Here we go.
So if we're
Look at you, artists. Look at this. This is pretty good.
Pretty poor drawing, but we've got the big hip bones here. Okay, the pelvis is what we would call that. We got the sacrum here. Okay, and then we got our lower lumbar or low back.
That's number 5.
Spine bone. Yeah, number 5.
And there's little discs in between, little cushions in between all those.
Exactly. So when we're talking SI joint pain, you're talking about this little area right in here. Okay, so.
SI means sacroiliac, just so it makes sense to, like, that's the sacral part is the sacrum.
Yep.
Where that triangular or wedge-shaped sacrum fits into the sacroiliac. That's just a name for that hip bone, your pelvis bone.
Yep.
There's 2 little joints on either side, but look at how close they sit to the L5 S1 disc space.
So the nerves come down between those disc space and eventually run down the legs. Okay. Just like that, they connect and run all the way down into your sciatic nerve. Okay, so a herniated disc, it travels. If that nerve gets irritated from that herniated disc, that space right between the sacrum here. Give it a second.
Okay, sorry about that, guys. We are back. Sorry. We've never had that happen before. We lost connection there.
I'll reiterate that here.
I think we just broke Facebook with that knowledge bomb.
Yeah, right. So we got the SI
dropped
joint here. We got the nerves that travel down in between the disc space. Okay, so if that disc space right here between the sacrum and L5 gets irritated, and that nerve becomes compressed, or the inflammation hits that nerve, it can definitely cause pain to radiate into this area, and that's definitely way more common than true SI joint pain.
And remember, the L5 S1 space is the most common area. So between 4 and 5 and 5 and 1, okay? Number 4 and 5, there's a disc there, and then 5, and then we call that S1. Really, there's just one. They're all fused. But that's where probably 80 to 90% of all your low back disc injuries happen between those 2 areas.
Definitely.
The higher up ones are not as common. So that's why it's so, it's difficult to differentiate those. But the way you do it is through specific movements and loads and your body's mechanical response to those loads is how we tell whether it's a disc problem or a SI joint problem.
True.
But you're also, like you said, you're leaning more towards, again, you're much more common to have a disc issue as opposed to an SI joint issue, because explain how tight how strong that joint is.
So the SI joint itself, if I redraw this over here. Good. So it has a bunch of ligaments that extend here on both sides, and then you have more coming from the femur itself, attaching here and attaching here. So those are some of the strongest ligaments in the entire body.
That joint literally does not move much. It's pretty fixed.
2 degrees of motion, which is like a piece of sand. There's not much movement.
Think of this kind of like, and tell me if this is the way you think of it. I think of kind of like the keystone of like the where your hips and pelvis fit into your spine.
Yep.
This is like the keystone of the. I mean, it's in there.
It's
It allows us to bear weight.
Yes.
And put weight on our backs and carry things, and it's a very stable joint.
Yep, I agree.
Where this one is much more soft, like the disc is much more soft and movable.
Yep.
Now, are there SI joint problems that people have? Absolutely.
Sure, absolutely.
It just yes,
Yeah.
it's just gonna present itself in a little bit different way.
Definitely.
And then her other question was, can you see an SI joint pain on MRI? You can't see a pain on MRI in anything. It doesn't show pain. It only shows what's there. Think of it like a picture.
Yeah.
Like if you see a picture like this, and you see like there's these nerves and there's this area here, well, you don't know if this person is having pain or not. You just see a picture.
Yep.
Now you could see maybe some separation, or if there's a serious enough SI joint problem, you could see some really big gaps.
Definitely, but that's pretty uncommon.
Typically, that does not happen. Yeah.
Cool.
So, Alana, I hope that answers your question. If you have any follow up or we didn't make sense on something, please reach out and we'll come back to it. I see you had something further down. I'm going to get to that. Okay. Let's go to Tyler here next real quick. So Tyler says, I have this thing in my neck for 3 weeks now that if I turn too far to the right, it hurts and gets tight. I lift daily and believe it came from that. Any guesses to what I've had going on? Okay, another good question. You guys are killing it here today. Okay.
Yeah.
Let's come back. We'll flip this back around.
Yep,
flip this back around, see if we can get in focus here. There we go. So what Tyler's saying is when he has pretty good rotation to the left, but when he turns to the right, he's like, oh, that gets tight. He can't go as far. I'm guessing he's probably feeling something on that right side as he goes into that side. Explain kind of what we would be looking for on that, with an obstruction or a loss of motion.
Right.
And then Tyler, follow up, is it consistent? Like every time you turn that way it's tight? Or can some days you go really far and some days only like half the way? Like does it vary? Is there variability? That's how we would kind of, start with some questions. But what else
another
would you
thing
look
I
for?
would like to know is what lifts he does, because that could give us a better idea of the mechanism of injury that would play into the role of him turning to the right.
Just trying to be a fun guy. Will the Packers win the Super Bowl? That is not what this answer session is about. And the answer is no, they will not win the Super Bowl because they didn't add the right pieces in place. Anyway, we're not getting into that.
Yeah.
Green Bay is my team, and I'm worried about them even winning tonight against a team that has no offense, but we'll see what happens. Okay.
So we would definitely start with it varies, but there's always some days it hurts worse.
Okay, variability is good.
That tells us it's mechanical.
Yep.
So, one of the things we'd look for is we'd obviously check ranges of motion to see what exactly is going on, where you're restricted, and then that can give us an idea of why you're restricted. So then we can test some different ranges of motion, repeated movements, feel the musculature around the area, see if the shoulder's involved, because the shoulder and the neck
it feels like you can't get all the way up here to the side or to the front or behind the back.
Yep.
It could be like actual trap or muscle tightness, possibility.
It could be a true neck issue.
Or it could be something deeper into the neck. Yeah.
And it's hard to say without doing a true exam.
Here's what we do though. Here's what you should do. Pick a direction and work into it and see if you can get some change to that right rotation. So here's what I would do. I would sit tall. Yep. Actually, you show me. So from the side, I would go tuck in.
Yep.
Tuck in. So if you can get that far and you can produce that pain to the side, I'd keep working into that 10, 20, 30, 40 times, really tuck straight back, and then return to the right.
And see if that changes.
See if it's any different.
Yeah,
yep. If it's like, I can go further, or it's less far. Oh, no, it's worse. Okay, at least it tells us that it's a neck like deeper down in the neck problem, not like a muscle problem to the side. Because we can't stretch out your muscle or change your muscle in 10 or 12 reps. But deeper down in the joints, but in the actual the way the bones and joints move, those can change pretty quickly.
Definitely.
So actually, Tyler, do that for the next day, and then get back to us and see what's going to happen with that one.
Okay.
I want to go back up to Alana quick because she said, so I have a herniated disc L4, L5 with right nerve compression. So we already so she's fitting into the model that we just drew, right? Between 4 and 5, very common. Right nerve compression, but all my pain is on the left side, and they keep having to realign me every week because my left leg is always shorter than my right. Okay, well this could be a good question for you then too.
Yeah.
So on the chiropractic side, tell us what you would look for on the chiropractic side. But Alana, real quick, just because a picture shows you
was
have
gonna go there.
okay, yeah, go ahead.
Yeah.
Go ahead.
You're,
just because the picture shows you have
Yeah.
a little bit of a herniated disc to the right side and some nerve compression, that has what matters most is your symptoms, what you feel. It doesn't matter what the picture shows.
Yes.
If you feel pain on the left side, your problem is on the left side. That's totally okay. You can have terrible looking X-rays and MRIs and everything like that on one side, but you're like, I feel it on this side. That's the one that you have to work on. So I remember this. I remember seeing you post this before. What she gets, and tell me, you get on here, Alana, and tell me if I'm wrong, but when she gets an adjustment and they realign the pelvis, she gets very quick, very quick, immediate relief.
Okay.
But I don't think it's long lasting. So she has some kind of functional, probably not anatomical, but which means like an actual leg, but probably some kind of functional leg length discrepancy where there's something, moving or shifting. And then when she gets adjusted, now she's going to need some movements to help keep
That's
that.
exactly where I'd go.
Okay,
with that.
you go with that one next.
Yeah. Any other questions?
No, just explain what you would do with
okay.
As from a chiropractic standpoint, you know that she gets relief with the adjustment,
Yes.
and then where should she? Because I'm guessing she's not doing anything.
Yeah, it sounds like she's not getting any therapy to go above and beyond the adjustment, because the adjustment itself is a great tool.
Yeah.
Right? And it can provide you quick pain relief and more range of motion.
Yeah, she said yes. It only lasts like 3 days.
If I'm twisting wrong, but it's so annoying.
Yeah.
Okay.
So she needs some movements to help with that.
So the adjustment's temporary. We need repeated movements or rehab, some sort of movement that we can repeatedly go into to retain that quick increase in range of motion and retain that pain reduction. And the fact that it changes your pain
that quickly. So it's clearly mechanical.
Yeah,
that's the good
mechanical.
news. Yeah,
so that tells us
they're halfway there. We just got to get a little bit more on top of it. Yeah.
That tells us you'll respond to what we call directional preference or directional movement.
Repeated movement, something for home. I would show Alana try to go into, pick a direction. So either try to go into flexion, knees to chest, like flex, or try to go into extension.
Yep.
One of those two, you'll notice like, it helps and it lasts longer, or no, it throws me off. Like now I'm way out of, like now I can't even move. Then you'll know that is wrong.
Exactly.
But
you just need more on the therapy side. It sounds like.
Yeah, I'd probably have her flex first.
Just
to see, because it stays in the back, it doesn't go down from the left side. Although we know she has, let's go through this. We know she has some kind of herniated disc on the right side.
Okay.
So we don't want to cause anything that's that it's there
Correct.
on a picture, but it's not symptomatic necessarily because that's left-sided. So let's go with extension.
I'd go with extension.
Let's extend.
I'd extend.
So do the hands low, here. Press up real high, let the back really sag down, and lots of them.
Yep.
50, 60, 70 of them. Once you get that adjustment, for the next 3 days, you're going to do 60, 70 of those a day, and see if now it's lasting for, the whole week or longer.
Yep.
And then we'll know if we're on the right track. If not, you let me know, and I'll. Yeah. So,
I think David said something up above.
Yeah, Captain Bailiff is he knows exactly what we're talking about. He just wants to give us a little shout. And we want to give Captain Bailiff a shout too. But Manharaz says, I have a herniated disc, by the way, L405. They say it's not bad enough for surgery, but I'm in pain every day, especially in the mornings.
So
yes.
We can talk about that.
Yes. They're saying maybe arthritis. Would you recommend surgery? My hips hurt now as well.
Okay.
I also had 2 epidurals and one went bad, where I needed a blood patch. Okay, so we're talking. We got some things to unpack here, which is fine. This is what we're wanting it to help with. So 4-5, which is actually okay. It's good news. If it's not bad enough for surgery and they don't want to do surgery, that's fine.
That's a good thing. Yeah.
Like, let's talk about maybe starting on a conservative route. Now you've already done some other stuff even more than. Conservative with the injections, and those can be helpful at times.
Yeah.
Obviously, one for her was bad. It's actually very normal to have worse pain in the morning.
Definitely. We'll get the model.
Yeah. Arthritis can happen as well. I mean, that's a natural part of our aging process. As we get older, we're going to get some arthritic changes. Things are going to kind of move and change, degenerate. But if you feel better with movement and you're stiff right away in the morning, those Discs, yep. So
throughout the day, we've got gravity beating us down, so that disc space kind of gets smaller and smaller and smaller and smaller. Okay.
because of just body weight and gravity pushing down.
But when we're laying down at night, we don't have that gravity pushing down, so those discs, they imbibe fluid, they swell up is basically what that means. So they get a little bit bigger, a little bit bigger, a little bit bigger. So when
they get their nutrition from the fluid that's around them.
Yeah.
They don't get great blood flow to them. So what they need is kind of like a sponge. You got to load them and unload them. So what Jake's saying is when you're laying down at night,
Yep.
they're hydrophilic water. They love water. So they want to get big. Yeah. So if you already have a little bit of a bulge, it's going to be a little bit
more painful in the mornings. So early movements in the morning, we can get that bulge to pop out because that disc is swelled up. But as we sit throughout the day, that whole disc gets pressed down, and we don't have that bulge as large.
So the day can get a little bit better as the day goes on.
Right. Yeah.
So right away in the morning, a good strategy right away in the morning would be to probably roll to stomach, flat, maybe just kind of prop on the elbows.
Yep.
Just slowly think about, putting pressure and kind of milking that excess water or fluid, it's interstitial fluid and all that stuff. Just slowly kind of pumping that out of there before you stand up and load it. Because then as soon as you stand up and load it and then go to the sink and brush your teeth and bend over, it's oh my God, it's terrible pain when you try to bend early in the morning. So just take a little bit of time, 30 seconds, a minute, to the stomach, maybe slightly on elbows, a few light little extensions. And then when you sit up on the edge of the bed, maybe kind of get tall, maybe just a little bit of a slouch, maybe get tall again, before just getting up, up on top of that tissue that's already, kind of herniated, and now with a little extra water, it's more herniated.
Yep.
Anything else you suggest with a little bit of morning pain?
No, I think that was great.
Okay.
Maybe avoid any heavy lifting or heavy flexion activities.
Yeah.
Not that it's bad.
Yeah, getting pulling, really flexing early in the morning.
It might just irritate.
Get up and walk a little bit.
Yeah,
Easy. Cause I bet she feels better as she walks around.
Okay.
Okay. Let's see here. Okay.
Bring them on.
Okay, and Alana says she should try inversion table. And so the theory behind that, and that does help some. There's a percentage of people that do well with a traction force. Basically, all that is you take your body weight and you lay upside down, and gravity then separates things. There's a percentage of people who do well with that, but that for some it's very temporary as well. They just feel they feel better while they're upside down, and then once they load again, it comes back again because they never actually move the offending tissue out of the way. They just give it some more space temporarily, and then it comes back again. So in combination with maybe some other movements, very possible.
Gotta have a.
And then so she's asking, Manharaj is asking, what's the best sleeping position and mattress? And so what would you say for sleeping position for her? I mean, you gotta sleep, and you gotta be able to.
Comfortable for you. There is no best position.
No.
If you have back pain, specifically with flexion activities.
Sometimes, here, show a.
Then you might want to
I'll flip it around again. There we go.
This would be a little exaggerated, but you might want to lay on your back with your legs propped up on some pillows so your back stays flat.
Yep. So a little bit of elevated legs. That's a little far. Actually, we got pillows here. Here, go on the table. The other way is kind of like a half, somewhat like a roadkill, kind of prone, kind of side lying, to just get a little bit of. Here, lay this way. Yep.
Just prop some pillows up.
So maybe just a little bit of to get slight flexion underneath the legs, so then it kind of flattens that out a little bit, less of a curve. But another way would be go side. If you're right-sided pain, I would lay on a half prone, half on the left side with that right leg kind of bent. Yeah, like that kind of roadkill position, where you got this right leg. This is the painful side here. And he's kind of up just a little bit. He's somewhat on his side, somewhat on his stomach. I'd put a pillow up there. It can kind of rest up there like that. Yeah, like that. That sometimes is good for people to have that painful leg bent a little bit and kind of be in a somewhat prone, meaning stomach face down, and somewhat side lying. But like Jake said, it's whatever you can get into so you can sleep. I mean, you got to sleep. or you won't heal. Sleeping is very important to the healing process, to the blood flow. Like we said, like Jake talked about with the discs. At night, when you go into deep sleep, you need that time for those discs that are injured to heal, because they want that oxygen, right? So oxygen is carried from the blood. So you got to have that circulation of the fluid, of the blood, to bring oxygen to the area so it can heal. So you have to sleep, whatever you need to do, whether it's on your side lying, painful side up, some people like painful side down.
Yeah.
Like it kind of closes that down a little bit. But however you need to sleep, but then in the morning, roll the stomach and try to slowly get moving. Hey, Brooke's watching. She's got some questions, I'm sure.
Yeah, Brooke throws some questions.
Look at that. Another smart PT right there. Okay, that's how I sleep, and a pillow between my legs. Yeah, okay.
Perfect.
So that's normal for what I'm saying is, or what we're saying is, it's normal for you to be a little bit more sore in the morning. Yeah. That's part of the healing process. You just have to know what to do to kind of pump some of that excess fluid out and then get moving. Let's see, losing weight help. I just can't work out. Well, okay, so being as fit as possible is always a good thing. Yeah. But listen, I think it's completely blown out of proportion when you go to the doctor and they say, "Oh, I have back pain." Oh, well, because you're fat, lose weight. People of all sizes get back pain. True. So what do you tell the person who's super skinny that has back pain? You tell them to lose weight? Like it happens to people of all ages, yep, of all sizes. It's not a weight issue. It's usually a load and a too much, of one position, yep, movement. It could be a fall or an accident. Yeah, there's different, yep, reasons why. But once you get it under control and you get it healing and it's fixing, it's remodeling, it's rebuilding, you're getting stronger, then yes, we totally are in favor of, getting on a consistent exercise program, on a regimen, because being as fit as possible and feeling as strong and healthy as possible will absolutely help you. Does it prevent it from ever happening again? No, but it helps you to be able to continue, feeling good. But I suppose we better. We have people here now. Oh. Ellen just left me a message that we have. You know what? So, that turned out way better than I even anticipated. I thought maybe we would kind of ramble and people were like,
"What are those?" Again.
Yeah. So we'll set it up again. The questions were amazing. I thank you guys very much. Okay. So then she said, "Is there a permanent fix surgery? Please say yes." So yes, I mean, most people do not need surgery.
The large majority.
The large majority. Well, only about maybe 4 to 5% actually need surgery.
Yeah.
But this thing is absolutely fixable, and the majority of people have a good recovery. The pain goes away. You feel better. But then you need to get on. See, what happens is when you feel better, you think that, I'm good now, so I don't have to do anything. No, you still have to, once you get it resolved, stay consistent with, again, the repeated movements, the things that help reduce the problem in the first place, now become your prophylactic or your preventative. I mean, I use that word loosely, but it does help. The biggest predictor of future low back pain is previous low back pain. So if you've had it once in your life, if you've had it and I've had it, Jake, I don't know if you've had it, but I've definitely had it. The chances you get it again are high, very high, unless you do something about it proactively. The stretches, the exercises, strengthening. You got to stay active and keep it, and that lessens the chance. It's still possible, but it lessens the chance.
Yeah. So where are you located?
Right now we're in Elkhorn, Nebraska. So kind of the middle of the country. Omaha essentially is where we're located, the biggest city by us. So, but yeah, people get very confused with the idea that a herniated disc is not fixable and you'll always have problems. And it's because once it goes away, then they go right back to doing the same. They didn't change their lifestyle at all. So the chances it comes back are high. I'm in LA. That's okay. LA, you know what? We can help you virtually. I have programs involved. With herniated disc programs to bring you back to a high level of fitness and feeling very good. And it can be done virtually through an app and along with calls like this. Monitors just reach out to me, send me a message. We'll get on a call. We can do a video call and we can help you even. Virtually. I have patients that I have actually a guy I'm seeing in a little bit that lives in California right now. We can do it over the video right now. He's down in Southern California. So,
good.
Arturo. I'm going to talk to Arturo a little bit later today. So we have to go for now, but I thank you very much for everybody that hopped on, and we will do this again. Let's do it next week. Let's do it again next week.
Cool.
Thank you guys. Reach out with any more questions.